de la UNAM. En esta ocasión abordaremos un tema crucial para el presente y futuro de nuestras profesiones. Ese tema es derechos digitales, acceso a la salud e inteligencia artificial. Nos encontramos en un momento histórico en el que la expansión de tecnologías digitales y sistemas basados en inteligencia artificial están transformando profundamente la manera en que prevenimos, diagnosticamos, tratamos y acompañamos a las personas en sus procesos de salud y enfermedad. Sin embargo, esta transformación no puede analizarse únicamente desde la eficiencia o la innovación tecnológica. Debe examinarse desde un enfoque de derechos. ¿Quién tiene acceso real a estas herramientas? ¿Cómo podemos proteger la privacidad, la autonomía y la dignidad de las personas? ¿De qué manera prevenimos sesgos algorítmicos que puedan profundizar inequidades ya existentes? Esta sesión profundizará en el marco conceptual y normativo de los derechos digitales en salud, analizando su vínculo con el derecho a la protección de datos personales, la confidencialidad de la información clínica, el consentimiento informado en entornos digitales y la gobernanza ética de la inteligencia artificial. Revisaremos cómo los sistemas algorítmicos influyen en la asignación de recursos, en los procesos diagnósticos y en la estratificación de riesgos, así como los desafíos relacionados con la transparencia, la explicabilidad y la rendición de cuentas. Asimismo, reflexionaremos sobre la brecha digital, los determinantes tecnológicos del acceso a la salud y la necesidad de desarrollar competencias digitales críticas en el personal sanitario para garantizar una implementación responsable, segura y centrada en las personas. Porque todos y todas somos corresponsables de construir una salud digital ética, inclusiva y socialmente justa. Sean nuevamente bienvenidos y bienvenidas.
La siguiente. No. La anterior. Yes, gracias. Gracias a todos por su asistencia. La doctora Davis, Meg, es profesora de salud digital y de derechos digitales en salud. Es directora de investigación en el Instituto, en el Centro Interdisciplinario de Metodologías de la Universidad de Warwick y trabaja actualmente como profesora del módulo IM 961 del Global Digital Health and Human Rights en ese mismo centro. Ha trabajado desde 2026 en aspectos de salud digital y del proyecto de derechos en salud digital en Genève Graduate Institute. Previamente ha realizado algunas investigaciones en el Centro de Derechos Humanos y Justicia Global en la Universidad de Nueva York. Ha trabajado también en la Escuela de Leyes de Columbia y en la Universidad Fordham. Obtuvo su maestría y doctorado en la Universidad de Pensilvania con una estadía postdoctoral en la Universidad de Yale y también en la Universidad de California en Los Ángeles. Ha sido visitante de derechos humanos en la Fundación Global de ayuda a pacientes con VIH, SIDA, tuberculosis y malaria, y ella institucionalizó esta garantía de atención en 120 países. Además, se ha publicado en diferentes medios, es autora de la publicación Políticas y Data en Salud Global, y además ha hecho publicaciones en el British Medical Journal acerca de los derechos humanos en salud digital. Meg, thank you for your participation and welcome to this Faculty of Medicine to the National University Autonomous of Mexico. Adelante.
It's really a pleasure to join you. Good morning, good afternoon, and I only wish I was there with you in person in beautiful Mexico, but as it is, I'm here in less beautiful London. Thank you so much for this opportunity to share some work and some lessons and reflections. And I really look forward to presenting and then to hearing some of your reactions and questions from your own expertise and experience. So I understand we have about an hour together, and I have a presentation that maybe 40 minutes to share with you, and then I look forward to the conversation. And if you ask me in Spanish slowly, I might be able to understand, but otherwise I might have to ask for your indulgence and apologies if my Spanish is not good enough to do this in Spanish. I hope that that is visible. Please tell me if it is not. So I wanted to begin by introducing to you my colleagues who are really the inspiration for this talk today and have been a source of great insight and learning over the past 5-6 years. And this is the Digital Health and Rights Project. We are an international consortium of human rights groups, universities, networks of people living with HIV activists, and scholars working together in Bangladesh, Colombia, Ghana, Kenya, and Vietnam, not yet Mexico, but you never know what the future holds. And we're really exploring together how the digital transformation of health is changing human rights, especially for young people whose needs are rarely considered in digital health and in AI for health. And that is young adults who are living with HIV, who are sex workers, who are LGBTQ+. And so we are learning together, reflecting on the lessons from the HIV response, lessons about marginalization, stigma, discrimination, inequality, how that shapes access to and inclusion in health systems, as well as lessons about how people have been able to mobilize in communities, both locally and transnationally, to create meaningful, to mobilize funds, to govern and to change laws and policies, to create an enabling environment for health. And thinking about how that example from HIV might be useful to inspire thinking and research and activism across borders in the digital age. So I'm going to propose these 3 lessons that we have learned. And the first is that human rights, while it was conceived in the 20th century, remains useful today for community empowerment, mobilization, solidarity across borders. And second, that digital access and inclusion is profoundly intersectional, that it's shaped by gender, race, geography, class, language, obviously, but many other factors that create inequalities in health, also create inequalities in digital health. And thirdly, that to strengthen governance of digital technologies and artificial intelligence for health, we need now to find ways to mobilize new forms of community power and new forms of meaningful participation to shape this governance and ensure that these new tools meet needs and not only private sector needs. So these are my assertions, and I plan to talk about this in my talk today. And to begin with, and I apologize if this is known well to this group, but I want to start with the Universal Declaration of Human Rights and the 10 core human rights treaties, including treaties on civil and political rights, economic and social rights, women's rights, rights of migrants, rights of persons with rights of persons with disabilities, indigenous peoples, and others, that these are the body of human rights norms and standards. These are ratified by countries, and most human rights treaties are ratified by most governments today, and the governments in ratifying these treaties then commit to implementing them through laws, policies, governance, and public education about rights. And countries then report to the United Nations and to regional human rights mechanisms and to their peers, to other governments, about their progress in upholding these norms. These human rights treaties create rights holders, which is all of us, and rights bearers, And I like to include photographs of activists in my slides when I talk about human rights. This is a group from Cartagena of activists on the International Day of Trans Disability, public protests. Because I find it inspiring to be reminded by the work that people have done. So governments have the obligation to respect and protect and fulfill human rights, and numerous treaties uphold the right to the highest attainable standard of physical and mental health. In particular, the foundational treaty is the International Covenant on Economic, Social, and Cultural Rights. And Article 12 of that treaty upholds the right to health. And this is further elaborated in the general comment number 14, which explains that the right to health is not just a right to be healthy, it is a right to a variety of factors that ensure access to the highest attainable standards of health services, information, facilities, and goods. And so the core elements of health, as set out in this treaty, include the right to non-discrimination. So this means that people cannot be discriminated against in the health system based on gender, based on race, based on disability, based on health status, or other protected status set out in human rights law. And it includes the right to what we call sometimes in English, AAAQ, AAAQ, availability of hospitals, medicines, trained staff, nurses, etc. Accessibility, so those facilities need to be physically accessible and they have to be affordable, economically accessible, so that the public can use them. They have to be acceptable, both from the level of medical ethics, but also they have to be acceptable culturally and acceptable to people of different genders. And they have to be of high quality. So health services and information must be scientifically sound and they should be regulated. It's understood in the treaty that not all countries have the same resources to fulfill the right to health. And so, for instance, where I am right now in the UK, one might think should have the resources to fulfill the right to health for all who live in the United Kingdom. But in other countries, there may be less resources. And so it recognizes the obligation to progressively realize the right to health. So the countries should be progressively improving, progressing towards meeting the standard of the highest attainable standard of physical and mental health. And there should be non-retrogression. So that means no backsliding. So if you reach a certain standard for the right to health in the country, you should not be retreating from that and removing that access. So for instance, in the United States, where I grew up, removing universal health coverage would be seen as retrogression, removing and backsliding the right to health. And countries finally are supposed to dedicate the maximum available resources to fulfilling the right to health, and they should be prioritizing this right over, for instance, the need to develop rocket ships and go to outer space, or other things that are not immediately needed by the population. So those are core elements of the right to health. And of course, today in the digital age, we face new challenges because we have growing youth populations, and especially in English LMICs, low and middle income countries. We have a youth bulge, but this means that youth may have differential access to health services. You can see on the left there the slide showing the boom in youth populations, especially in some African countries. And on the right, you can see the share of population using the internet. And if you look at Africa, you can see that is the lightest blue. That is the region with the least access to internet. So while there are many more young people who might be expected to be going online, looking for information, accessing telemedicine, looking up their prescriptions, etc., but they may not have access to the internet. And especially in rural regions, especially young women, especially people in poorer socioeconomic settings would have less access to the internet and thus less access to online health services. So while we're all very excited about the potential of digital technologies and AI for health, that potential is not reaching everyone. And I'm sure that when we have youth, be able to share examples also from your experience in communities of people you know who do not have complete access. In my case, my mother, who was from New York, actually, not access her online health information and services without technical support from my brother. And so, for many of us, older people, persons with disabilities, people in rural settings, we may be able to identify people we know who have less access to digital health. This was elaborated really beautifully by Dr. Talon Motherheng, who is the UN Special Rapporteur on the Right to Health. So that Human Rights Treaty I mentioned, the Covenant on Economic, Social, and Cultural Rights, her mandate as Special Rapporteur is to uphold the right to health set out in that treaty. And so she issues reports and analyses of different health rights issues. And she, in 2023, working with the Digital Health and Rights Project Consortium at that time, developed this report explaining how the right to health applies to digital technologies and AI for health. And she talked about AAAQ, as I just mentioned, availability, so this issue of coverage, Wi-Fi, access to phones, and how this can affect your access to availability of health services, information, and telemedicine. She talked about accessibility and how having services go digital for health might unintentionally exclude older people or persons with disabilities. She talked about acceptability, in particular in the age of AI, when many people are going online to use ChatGPT or other tools to get health information. Is that information acceptable for diverse cultures? Is it fit for purpose for diverse languages? And then quality. If you think about AI and digital technologies, there are many pilots. It's almost like a plague of pilots in many countries with new tools, new approaches, and they're not always very well regulated. So sometimes they are piloted. Particularly, there's often a situation with universities and companies in Europe, US, who are piloting new interventions in low and middle income countries, but aren't as regulated by the health authorities in that country. She talked about non-discrimination, including the issue of biases in data, biases in the design of tools for health, and the right to privacy, which is really critical for health data, because we all have the right to privacy, and in particular, privacy violations can be very serious for people who have stigmatized diseases or live in situations where they cannot share their health status with others. So health data must be protected as sensitive data. And she also talked about some of these other aspects of governance, digital technologies and artificial intelligence for health, transparency, accountability, explainability, ensuring that AI for health is open source. Whereas we see the norm increasingly is the expansion of cloud services based in the US or based in Europe, web services, again, that are under one jurisdiction, US, what some people call data colonialism, the extraction of data, including health data, from low and middle income countries for profit by private actors in high income countries. This is, again, a problem of sovereignty, a problem of transparency, accountability, and privacy in many countries. She also talks about the right to participation. This is one that I want to focus on a bit more in this next part of my talk. So the right to participation in decision-making is fundamental in human rights, and it is encoded in numerous UN norms and standards, and it's grounded in existing human rights standards, norms that are ratified in treaties, including the right to freedom of expression, the right to freedom of association, so the right to form your own organizations, the right to freedom of assembly, the right to gather with others, and the right to the high sustainable standard of health. We know that there are many wonderful examples of patient participation and public participation in development of health technologies and tools and the governance of these tools. And this is an important aspect of human rights upheld in national constitutions and laws. In the role of civil society, it's been very crucial to promote accountability. So we need to continue to uphold that in the increasingly privatized environment we live in the digital age. And in particular, I want to argue that we should be thinking about new ways to involve public, involve patients, involve end users, involve community health workers in research, in governance of digital technologies and AI for health. And this is increasingly important as we see growing widespread populism and issues with public trust in health, in digital health platforms and technologies, as well as cases of data breaches, fraud, function creep, which is when data is gathered for one purpose and used for another purpose, misinformation, disinformation, discrimination, bias, and privacy intrusions. And public engagement doesn't solve all these problems, but it does help strengthen the legitimacy of governance. It helps to strengthen public trust. And it helps to create more robust and well-designed technologies and tools that really meet diverse local needs. And this is in what in some cases we might consider to be epistemic justice, in which our rights as people who know things, our rights as knowers, are upheld, and our rights as participants in design to ensure that health meeting local needs and is not simply designed to benefit private actors in other countries. So the public approaches to design and governance are crucial, and it's easy to say, and in my own experience, much harder to do meaningfully. So I did want to flag some ways in which we can think about participation. And so for projects, for designing interventions, we can think about public participation as taking place when we develop the requirements, when we develop a sense of what the problem is, what kinds of technologies are needed, when we select indicators and data for a new AI intervention, when we collect data and label it, classify it, in the development of models, training models, evaluating and feeding back on models, in design, auditing of models, once they start to be piloted, and then deciding whether or not to adopt things and bring them to scale. So at each of these different stages, as you see on the left, there is potentially an opportunity there to include the public, to include end users, to include diverse communities, to give feedback on some of these things. Likewise, on the right, you see the policy development circle, sort of classic circle of how we develop policies. And it's a similar process in that it includes the stage of developing problem, gathering data, identifying the issues, mapping out existing policies and seeing where the gaps are, drafting new policies, consultation, and coordination to implement policy. And here again, at every step, there is space to include public, to include patients, and to include diverse communities to ensure that policies are really fit for purpose and actually address diverse needs. And I also wanted to note that this is the problem of new participation in a way that is meaningful is a problem that's been around for many generations. And Arnstein, in 1969, created this beautiful ladder, some of us may have seen before, to show that, participation can happen at many levels. So there can be a one-off consultation where people come in, are briefed on the problem, give their ideas, lead. It could be at the level of just informing people about a decision that's already made, but it could be at the top, citizen control, where people not only give input, but get feedback, have voting power, and have equal power to decide if the policy is going to be implemented, or if the AI technologies can be used. So the public could come in at many different stages in this process. And it's important to think about how to create structure for community power that allows people to participate in a way that is meaningful for them and is not just tokenism. It's not just them giving a thumbs up to a policy that was already decided by elites. So somewhere in between a process that they completely control and a process that elites completely control, there is a big range of possibilities for what could be participation. There are many different definitions of this, including within AI and development of participatory approaches to AI. So for my project, which I'll talk about in a minute, and then look forward to hearing your voices too. So in our project, the Digital Health and Rights Project, As I mentioned, we have been very much inspired by and instructed by the experience of people living with HIV in key populations in the HIV response. And this goes back to 1983, when a group of people living with HIV gathered in Denver, Colorado, to demand a right to participate in decisions that affect their lives, and to say, we don't want to be called patients, we don't want to be called victims, we want to be called persons living with HIV. And 40 years later, that initial movement has grown to a massive global movement, now significantly affected by Trump and other funding cuts, but nonetheless, still a very powerful movement, with people from affected communities participating in governance and decision-making at many levels in many different countries. And they have different publications, some of which are listed here. One is Y Plus Global, where young people living with HIV describe how they want to participate. How do they consider they should be consulted and engaged in decision-making about the HIV response? Stop AIDS, which is a UK-based network, consulted with networks in other countries, developed a set of principles for meaningful involvement of communities in civil society health governance that talked about some of the things they think are crucial to include. One of those things is including structures to make it sustainable, so that it's not just a one-off consultation. You bus people in, tell them what your decision is, they say, "Hey, sounds good to us," and then they leave. But have sustained ongoing conversations in which you are working with a group of community representatives who get to know each other and who have funding to support your time and other support to enable them to participate meaningfully. So for the Digital Health and Rights Project, working in Colombia, Ghana, Kenya, and Vietnam, we've established 4 community advisory teams. Each one is hosted by an NGO or a university. So the one in Colombia is hosted by Universidad de los Andes, and the others are hosted by NGOs in other countries. And in each one of those community advisory teams, they have a group of about 10, 12 young people who in turn represent other networks, constituencies, and they have come together to participate in our research, to mobilize participants, to lead discussions. Sometimes they help lead focus group discussions, analyze data, and they sit on our global governance board, on our global steering committee, and exercise a vote equal to me as the principal investigator and to every other executive director of an organization on our board. So that means from the community to the global and back again, we have community representation throughout our project. This report here is the most recent report, which you can see, and this is from the Digital Health and Rights Project, based on engagement with 300 young adults from those 4 countries I just mentioned. It was participatory action research, in which study participants co-produced the research, analyzed the data with us, and then they are leading the advocacy in many different countries and globally, engaging with UN agencies and funders. And the study found, read the report, we will have a Spanish translation up very soon, so please follow us for that. But they found essentially that many young people use their mobile phones to search for health information services are talking about experiencing online abuse, verbal abuse, stalking, cyberbullying, and more. And they have privacy concerns because many do not afford their own smartphones and have to share phones with peers and family and partners. And because many are living with HIV or are LGBTQ or sex workers, there was a lot of fear of stigma and privacy intrusions. Now they're using these findings in advocacy. 3/4 of the young adults in our study describe online abuse. And I think when we talk about digital health and AI for health, we have to understand that for us, who work in this field, we may see it as a separate thing that only happens within the health system. But for young adults and for many people, you use your phone to get online, to book an appointment, to check your test results, order something from a pharmacy. You might also be using TikTok or Instagram to look for health information. You might be going on WhatsApp, chat with people. You might be going on dating apps, look for companionship, and all of this is happening on the same device. So for young people in our study who experience bullying and abuse and harm, to them that made them in some cases experience psychological harm, and in some cases physical harm. People were lured into violent attacks in Ghana and Colombia, and also that it might lead them to be less willing to go online to search for help, information, or services because of what they had experienced with themselves or their peers. Most of the young people we spoke with in our study said they were not able to access remedy or support. Reporting to social media platforms was ineffective because the abusive account would be taken down, come back a day later, or it might not be taken down at all. And that many felt that going to law, going to police was not effective for them either. Either they weren't taken seriously, or they experienced abuse from the police, and therefore were unlikely to report. And so they talked about wanting to have more training on their rights, more support to bring complaints, to bring cases to others. And so that's what young people in our study are now advocating for. And this is a set of the recommendations. It really calls for all of us to recognize that access to health now depends on access to digital technologies, and that at the same time, accessing digital technologies increases the risk of online abuse, especially for women, people living with HIV, marginalized communities who are affected by HIV. And they also called for a survivor-centered approach in which we put the needs of the survivors first. We think about their needs for confidentiality and privacy, their needs to make decisions, their needs for access to health and psychological services, needs for access to justice. So this is moving towards conclusion. I wanted to share a little bit of what we've learned about participation in our project. And you can see here some of our young colleagues in Ghana who've been extremely active on the projects. We have found that it's very important to have a national NGO or a national university that hosts this community advisory team, that they then have a broader network of communities who are then able to advise and participate in the project. That we found that civil society and participants need a lot of time when they want to participate in our study, that they need time to be briefed, to debrief, they need time to make it sustainable, we need time for interpreters because we're working in many languages. We found it's very important to include not just civil society, but peer-led networks, so that we're not just working with HIV NGOs that provide services, but also HIV NGOs that are led by people living with HIV. And the young people in our project need to select their own representatives. Not be me saying, I like this guy, he says good things, let's put him on the steering committee. It needs to be the young people themselves, because their representatives should be accountable to the young people, ultimately to their community. We found that diversity is very important to the young people in our project, that they want to see not only young people who look like them, but also diverse people, diverse backgrounds, diverse sexual orientations and gender identities, diverse levels of disability, genders, everything. The more diversity, the more legitimate we believe our gatherings are. And we've tried very hard to develop an anti-oppressive approach in which we all reflect on our power and think about how to address power inequalities across our consortium. It's very large and diverse. And finally, we have identified the need for funding for projects that include so many different community groups. It's a continuing challenge. I'm sure everyone knows about this, but especially at the current moment, it's very difficult to get funding to sustain this kind of work. So I guess with that, I'll just wind up. I'm really looking forward to your comments, reactions. Please feel free to disagree. The challenge, I enjoy a healthy debate. I think just to underscore, for us, human rights has been very important in mobilizing communities, in identifying, analyzing problems, and finding solutions together to move things forward. We believe that digital inclusion is a fundamental human right. It is now a determinant of other rights, and so we continue to advocate for that. We understand digital inclusion and digital access is intersectional, that it's shaped by many different forms of inequality, and that we should never assume that everyone is online, because there's some shame now to saying you're not online. So many people face different barriers, and we have to be sensitive to those and find solutions for those. And finally, that to strengthen the governance of digital health and AI for health really has to be built on community participation. And there are really useful lessons to learn about how to do this from the HIV movement. So I'm sorry, I'm starting to lose my voice, but I did just want to share some of our articles and reports. They are also on our website, which is digitalhealthandrights.com. And I'm also wanted to share our online training tools. We have many now, including one on Coursera, which is in Spanish, developed by our colleagues at Hernandez in Colombia. So please check that out. And I'm happy to share the link also with your colleagues afterwards, if that's of interest. And finally, that's my email. My email is Sarah Davis, but my name is Meg. Most people know me as Meg. So please feel free to reach out. And I will stop there and look forward to comments, questions, discussion. Thank you very much.
Thank you, Meg. I appreciate your participation. I have two questions, three questions. ¿Nos prestan el micrófono, por favor? O ven, pásate para que te den. Sí. In Mexico, the Congress in past January modified the law to include digital health. ¿Está apagado o no? ¿Sí me escucha, no? ¿Ahí sí me escuchan?
Ahí sí.
Gracias. In past January, the Congress in Mexico include the health digital has a right, human right. In your experience, how many time we need to implant totally this human right?
Thank you very much. So if I understood you correctly, the Congress has passed a resolution to recognize digital inclusion as human rights. And that's really wonderful. I would love to see that and maybe share with some of our colleagues, because I think we're always looking for good models, good practices that we can share with colleagues, and especially with civil society and academics in different countries. I think we're at the beginning of a long journey with digital rights, and I think it's going to take a long time to include all the different diverse needs. So we have to really begin to understand, as I mentioned earlier, the diverse forms of inequality that can shape access and inclusion. And so one thing we have looked at in my project is the digital health strategies that different countries have drafted, working with the World Health Organization, and how those digital health strategies address human rights, address gender, address things like privacy, and most of them don't. So most of them, unfortunately, make no mention of women. Most strategies that we looked at made no mention of gender inequality, didn't address the digital divide, made very little mention of privacy. So I think it's just beginning. I think we have a long learning journey to go through to understand how to create digital health governance that really works for all of us at diversity. I hope I answered your question, but please ask me again if I didn't. Thank you.
Yes.
Hi, morning. First of all, I want to thank you for your absolutely brilliant presentation about digital health. I just have a couple questions I want to address to you, Professor Davis. First of all, I understand that as human beings, we are entitled and hold to the right to health. But unfortunately, here in Mexico, there are some regions that they can afford to have like Wi-Fi or digital devices. So my first question is, how can we help in those who are in this branch, and how can we help them to be participate in this transformation of the health? Because I believe that as I said, like we all as human beings, we have the right to the health, but how can we help them to be participate in the health of digital health? That's my first question. And well, I want to ask, I want to ask and make, I want to make another question, but if there's no time, I just want to say that. Well, my second question is about um, what you said about the strategies of the World Health Organization that you just said. And I say it's I didn't I just want to make my mind clear, but sorry about that. But how can we help those communities about the governance? How can we strengthen the governance in digital health? Because as you said, we all have our personal information in all devices, like in our mobile phones, for example. Like we hold WhatsApp, social media, and those apps have vital information about us. But how can we strengthen that governance according with the strategies of the World Health Organization?
Wow, wonderful questions. Thank you so much.
Thank you.
Yeah, I think the first question on how to help people in regions with Wi-Fi, I think there's already a lot of great creativity and ingenuity happening in those regions. I know that there are people in Mexico trying to create like their own cell phone towers and the cell phone access. There are, of course, things like shared Wi-Fi rooms where people can get online, in shared spaces, libraries, of course, if there are resources there. It is extremely difficult, right? And I don't know that I have an answer that you haven't tried already, or that people are not trying. But I do think it is important to advocate for coverage, and in particular for rural regions, and particularly I want to advocate for women in rural regions. Because in many cases, we found in our research, we didn't work in Mexico, but we did work in Colombia, as you heard. And in Colombia, we found that women in rural areas often had to use their husband's phones. So maybe there's one phone in the family and it belongs to the man because he has a job. And that meant that for women to get access to health information and services was extremely challenging. They had to make sure that their husbands gave them access, and sometimes their husbands wouldn't let them have access, or if they wanted reproductive health, they might not be able to access it if their husbands didn't agree. So I think that that is a real issue and one that might require some further research and some further convening in partnership with civil society and with local health authorities to understand the needs of women in rural areas and to make sure that we're supporting them to develop innovative solutions. And I did find in Kenya, in our study, that young women who did have access to smartphones sometimes became treated with much more respect. Suddenly, they were the authorities because they could go onto a web platform and do a search for someone's symptoms. They could explain, what the pros and cons of different medications were because they could access this information. So suddenly, young women might become authorities in their village if they had access to a smartphone. So I think doing more research, I know that's a classic academic answer, but I do think that that is very valuable, and especially because much of the research about digital health and digital rights has been done in the global north and is not very useful always in other places. So I think we need more locally defined and driven research. On WHO and strengthening digital health governance, I will share the link with Dr. Marie Martinez after this call. I'll put it in the chat if I can find it quickly for the Coursera course, because that's free of charge. So anyone who can get online can access it. And in addition, we have a digital empowerment hub where we have a lot of tools. I'm sorry, most of them are in English. but we might give you ideas for your own to hold discussions with communities about what their digital rights are. I always think it's very important when I'm doing research with young people to lead them with something. And so I try to have a little conversation at the end of a focus group discussion to explain how you turn off notifications on your phone, to explain where the data goes. It goes into your phone, who can access it, who can see it, to give them options that are not Facebook so much. Yes, that is the Coursera course. To give them options for like Signal instead of WhatsApp, or other things that are, less exploitative options, to talk to them about VPNs to protect their privacy. So I just try to leave them with a little something. And there is a good opportunity now to engage with the World Health Organization because they are developing their new global strategy for digital health. So this is a very good time to write to them, to hold consultations, to submit articles, to inform their literature reviews, make recommendations, to ensure that the global digital health strategy reflects the needs of people in Mexico and in other countries as well. Let me stop there in case there are other questions, and also I want to see if I can find the Coursera course link. And I see questions coming in the chat as well. Yes, thank you. Back to you.
Thank you.
Yes, we need alfabetización, learning in digital health, all with passions and physicians. Thank you. Dr. Campos, right, our government has introduced a national registry of telephone numbers linked to biometric data beyond the cybersecurity risk. Does they represent a human rights issue?
That is very interesting. The National Registry of Telephone Numbers linked to biometric data. I would think that's quite a risk. Yeah. I would certainly, I'm very anti-biometrics personally. So I personally try to avoid it whenever I can. It's difficult. But I do personally think that would be quite troubling. Yeah, certainly cybersecurity risks. And also I would think potentially infringement of the right of privacy. But of course, you have many great human rights scholars in Mexico, which I'm sure are working on this right now. But certainly I would find that quite concerning. Yes. And I wonder why that would even be necessary. So this is an important aspect of human rights standards, is to think about what is the minimal intrusion, the minimal infringement of human rights that is necessary for a legitimate government purpose. This to me, I would have to know more, but it does not sound minimal. It sounds quite intrusive. Thank you for sharing that.
Dr. Campos, right? In countries with major deficits in all fields, how come the communist decision makers, the respect for and the promotion of digital human rights are the priority?
No se escucha.
Pues ya está ahí, doctora Campos, dígaselo, por favor. Que no se escuchaba. Ah, ok. Vente para acá.
I have another question. Give me a second. Thank you so much for your presentation. It was very interesting. I am glad to see that digital health is being viewed from a gender and diversity perspective in other regions. So my question is, what strategies do you think we can use from our position as a medical students to make a significant change in digital health with a gender and diversity perspective?
Wow, wonderful question. Yeah, I would be interested in what we could do as medical students, because I think it depends very much whether you go into governance roles or whether you are thinking more in the future as a practitioner. But certainly, I think for students, to raise these concerns, to have these conversations, just in your capacity as students, is very important. I don't know if you all are members of IFMSA, the International Federation of Students Association. So they actually have done quite a bit of work on this issue. They're engaging with WHO on these issues around digital health governance, and I think would probably really benefit from some input from students in Mexico based on your experience and your insights. And just this issue about telephone numbers and biometrics would be very interesting to raise. So I would definitely encourage you to participate in these conversations through NGOs and through associations during your time as students, but also then to think about future as practitioners. What are things you can do to try to ensure human rights of diverse communities are respected in your work? And then maybe if you move up and become the heads of hospitals or public health senior officials, how then do you support policymaking that really meets diverse needs? So that's a bit of a general answer, but I hope it's a bit useful. But yeah, I'll definitely check out IFMSA and also Youth Stop AIDS. It's another network that has been working on these issues quite a bit as well. And Young Experts Tech for Health is another group that I would suggest taking a look at. So there are quite a few groups of young students and doctors and practitioners working on these issues. Thanks.
Thank you.
And here right now, I don't know if someone's speaking. Oh yeah, here we go.
Dr. Davis, Meg, thank you very much for this presentation. I send this recognition for your participation in the seminario, excuse me, en salud digital. Los esperamos el día 24 de marzo en nuestra próxima sesión. Si nos presenta, por favor, la invitación. Cartel tamaño carta es la última. Esa, gracias. La previa, todavía para arriba otra. Nuestra próxima reunión es la transferencia de conocimiento para que la sociedad vea todo lo que estamos investigando. Meg, thank you very much.
Thank you. It's been such a pleasure. I hope we get to meet in person one day. Wishing you all the best with your studies and research. Thank you so much for the time. Certificate.
Thank you. Bye. Gracias por su asistencia.